Welcome back to GynoMite, ObGyn with a bang, where we take women's health, sprinkle in some truth, and light it up with humor. Today we tackle the big one, the episode you've all been waiting for, hormone replacement therapy, or some of my patients call it, that thing I Googled at 2 a.m. that made me panic. So grab your patch, your cream, your pill, or your pellet, because we're diving in. Hormone replacement therapy, HRT for short, is exactly what it sounds like, replacing the hormones your ovaries used to make but now have ghosted you on. Estrogen is the headliner, progesterone plays backup and is especially important if you still have a uterus, and testosterone, well, she's like that band member who shows up for certain songs, not always needed, but often makes a difference. And no, estrogen won't turn you into Beyoncé overnight, wishful thinking. Estrogen is hands down the most effective treatment for hot flashes, night sweats, and vaginal dryness. Let me say that again. Estrogen is hands down the most effective treatment for hot flashes, night sweats, and vaginal dryness. We're talking the difference between sleeping in your bed and sleeping in your refrigerator. If you've got a uterus, you'll also need progesterone. Why? Because estrogen alone can cause your uterine lining to grow too much, and we don't want your uterus auditioning for the role of cancer risk in your biopic. Progesterone keeps it balanced. Testosterone, in most cases of low libido and fatigue, it helps. But newsflash, rubbing testosterone cream on your elbow will not turn you into The Rock. So, how do we get these hormones into you? Options galore. But first, let's talk about something called the first pass effect, or first pass metabolism, which is a phenomenon where a drug's concentration is significantly reduced before it reaches systemic circulation. This is particularly relevant for orally administered drugs that are absorbed in the gut and then transported via the portal vein directly to the liver. The liver is the primary site of this metabolism, and for oral estrogen, this process can lead to potential harmful effects. Number 1. Increased risk of venous thromboembolism, VTE. Oral estrogen, due to the high concentrations that pass through the liver, can stimulate the synthesis of various liver proteins, including clotting factors. This can lead to a procoagulant state, increasing the risk of blood clots. Studies have shown an increased risk of VTE, including deep vein thrombosis and pulmonary embolism in women using oral estrogen, especially when compared to transdermal or other non-oral routes of administration. Number 2, effects on liver function and metabolism. The high rate of estrogen required to overcome first-pass metabolism can have a pronounced effect on liver function. This can lead to altered production of liver proteins, including those involved in cholesterol and lipid metabolism. While some effects may be beneficial, for example, increased HDL or good cholesterol, others can be negative, increased triglycerides. In some cases, oral estrogen can cause or worsen liver-related complications, such as intrahepatic cholestasis, a condition where bile flow from the liver is reduced, and in rare cases, liver tumors like hepatic adenomas. Number 3, formation of estrone and its effects. During first-pass metabolism, a significant portion of oral estradiol, the most prevalent estrogen, is converted into estrone, another type of estrogen. This leads to higher than natural levels of estrone in the bloodstream. The clinical implications of a high estrone to estradiol ratio are still being studied, but some believe it may be associated with increased risks of certain estrogen-related cancers. Number 4, reduced bioavailability and dose variability. The extensive first-pass metabolism of oral estrogen results in very low bioavailability, meaning only a small fraction of the administered dose reaches systemic circulation. Number 5, other potential adverse effects. Some research suggests that the liver-related effects of oral estrogen may contribute to an increased risk of gallbladder disease or cholelithiasis. The first-pass effect may also lead to changes in other systems, such as the coagulation cascade and inflammatory markers. So, back to that question of how to get these hormones into you. Pills, yeah, they're easy, but they go through your liver. But it's important to note that the risks associated with oral estrogen are dose dependent, and for many women, the benefits of hormone replacement therapy outweigh these risks. However, the first pass effect is a key reason why non-oral routes of estrogen, such as patches, gels, creams, they're often considered safer as they bypass the liver and result in more stable physiological hormone levels with a lower impact on liver protein synthesis and associated risks. And that brings us to patches. Stick-on convenience, steady levels, and no first pass through the liver. Bonus, you get a free wax job every time you rip one off. Gels and creams. Rub it on, let it dry, and pray your dog doesn't lick it off. Vaginal inserts. Perfect if your only complaint is dryness, plus they double as the world's least fun suppository. Now, let's talk about various risks and benefits of some of the different hormones. The risks and benefits vary based on factors like age, health history, and the type of therapy. Potential benefits of estrogen replacement therapy, or ERT. Relief of menopausal symptoms. For the third time, ERT is the most effective treatment for hot flashes, night sweats, and vaginal dryness, which can cause painful intercourse. It can also help with other symptoms like mood swings, sleep disturbances, and brain fog. Bone health. ERT is a well-established method for preventing bone loss and reducing the risk of osteoporosis and fractures. This is particularly important for women who have premature or early menopause. Cardiovascular health. When started within 10 years of menopause or before age 60, some studies suggest that ERT may reduce the risk of cardiovascular disease. Other potential benefits. Some research indicates a reduced risk of type 2 diabetes and colon cancer. ERT may also have a positive effect on skin elasticity and muscle mass. Potential risks and side effects of ERT. Blood clots and stroke. Oral estrogen is associated with an increased risk of blood clots, deep vein thrombosis, pulmonary embolism, and stroke. Again, this risk is lower with transdermal methods like patches, gels, or sprays. Cancers. Endometrial cancer. Taking estrogen alone without a progesterone can significantly increase the risk of uterine cancer in women who still have their uterus. Breast cancer. Combined estrogen and progesterone therapy is associated with a small increased risk of breast cancer, which rises with long-term use. Ovarian cancer. There may be a small increased risk of ovarian cancer with long-term use of either estrogen only or combined therapy. Other side effects. Common, often temporary side effects include breast tenderness, nausea, headaches, bloating, and irregular vaginal bleeding. Dementia. When initiated in women age 65 or older, some studies suggest an increased risk of dementia. Important considerations. The benefits of ERT generally outweigh the risks for healthy women under the age of 60 or within 10 years of menopause who are experiencing moderate to severe menopausal symptoms. ERT is not recommended for women with a history of breast cancer, uterine cancer, blood clots, or certain liver or cardiovascular diseases. The type and duration of therapy should be carefully discussed with a healthcare provider to find the right balance of benefits and risks for each individual. And for progesterone. Here's a short list of the risks and benefits of progesterone replacement therapy in peri- and postmenopausal women. Potential benefits of progesterone. Uterine protection. The most important benefit of progesterone is the prevention of endometrial hyperplasia, which is an abnormal thickening of the uterine lining, which can lead to uterine cancer. When a woman takes estrogen, progesterone is necessary to counteract its proliferative effect on the endometrium. Symptom management. Progesterone may help alleviate some menopausal symptoms, particularly sleep disturbances, as it can have a calming and sedative effect. It may also help with hot flashes and night sweats. Bone health. Progesterone may contribute to bone health by stimulating bone formation. Mood. Some women report improved mood and reduced anxiety on progesterone. Potential risks and side effects of progesterone. Androgenic or male side effects. Some synthetic progesterones can have androgenic effects leading to side effects like acne, increased body hair, and mood changes. This is less common with bioidentical micronized progesterone. Common side effects, these can include breast tenderness, bloating, headaches, and mood swings, which are often similar to premenstrual symptoms. Increased breast cancer risk. When combined with estrogen, certain types of progestins have been linked to a small increased risk of breast cancer, particularly with long-term use. The risk with micronized progesterone may be lower, but more research is needed to fully clarify this. Drowsiness and sedation. Oral micronized progesterone is often taken at bedtime because it can cause drowsiness. Breakthrough bleeding. In some cases, taking progesterone can cause irregular vaginal bleeding, especially in the initial months of therapy. Important considerations. Progesterone is almost always prescribed in combination with estrogen for women with an intact uterus. It is rarely used on its own for menopausal symptoms, but it certainly can be in women who don't have a uterus. The risks and benefits can vary significantly depending on the specific type of progesterone used. For example, natural micronized progesterone versus a synthetic progestin. The dose and, as discussed, the route of administration, oral, transdermal, etc., will affect risks and benefits. Testosterone. Testosterone replacement therapy, or TRT, for peri- and postmenopausal women is a topic with ongoing research and varied expert opinions. While some benefits have been observed, especially for specific conditions, there are also potential risks and a lack of long-term safety data. Here's a list of some of the risks and benefits of TRT. Potential benefits of TRT. Improved sexual function. The most well-documented benefit is an increase in sexual desire or libido, an increase in arousal, pleasure, and orgasm, particularly for women with hypoactive sexual desire disorder, or HSDD, that's not responded to other treatments. Mood and energy. Some women report improvements in mood, motivation, energy levels, and a reduction in unexplained fatigue. Bone health. When used in conjunction with estrogen therapy, testosterone may increase bone density and reduce the risk of osteoporosis. Muscle mass. TRT likely contributes to increased muscle mass and strength. Potential risks and side effects of TRT. Androgenic or male side effects. These are the most common side effects and are usually reversible with a dose reduction or discontinuation. They include acne, increased facial and body hair growth, scalp hair loss, cardiovascular risks. The long-term effects of TRT on cardiovascular health are not fully understood. There is a concern that it may increase the risk of heart disease, stroke, and blood clots, especially at high doses or with oral formulations. Other concerns. Voice deepening. This is a rare side effect but can be irreversible. Clitoral enlargement. Also rare, but a potential risk. Liver problems. Oral forms of testosterone are not recommended due to potential adverse effects on the liver. Breast and uterine cancer. While some studies have been reassuring in the short term, there is a lack of long-term data on the risks of breast and uterine cancer with TRT. Important considerations. In many countries, including the United States, there are no FDA-approved testosterone products specifically for women. It is often prescribed off-label using male-formulated products at a reduced dose. TRT is generally recommended only for women who are already on estrogen therapy, but not an absolute requirement. The primary and only evidence-based indication for TRT in women is for low sexual desire that is causing distress and has not been helped by other treatments. More long-term high-quality research is needed to fully understand the safety and efficacy of TRT in peri- and postmenopausal women for conditions other than HSDD. WHI. Okay, let's talk about the elephant in the room, the scary headlines. The Women's Health Initiative study, or WHI, published in 2002. Overnight, doctors pulled women off HRT faster than Starbucks can pull out a new pumpkin spice drink. Here's the truth. The study mostly looked at women who were older, average age 63, starting HRT long after menopause. That's like trying to fix your car engine after it's already been sitting in the junkyard for 10 years. And I apologize for that analogy. For younger women starting within 10 years of menopause, the risks are much lower and the benefits, hot flash relief, bone protection, better sleep, are very real. I swear half my job has been unscaring women who read headlines in 2002. Okay, let's clear this up. Bioidentical hormones aren't some trendy buzzword. It simply means the hormone is chemically identical to the ones your body makes. Not close, not horse urine like the old school drug Premarin, identical. Your body can't tell the difference. When I was medical director of a nonprofit medical office, I ran a bioidentical hormone replacement program. What I loved about the program, I would check blood levels of different types of estrogen, progesterone, and testosterone after initiating or changing dosages of bioidentical HRT, then adjust the hormone doses for each woman individually based on their levels. Because here's the thing, not everyone metabolizes or excretes hormones the same way. I found that some women who were not able to adequately metabolize and excrete their replaced hormones had dangerously high estrogen or testosterone levels even on standard dosages, which would theoretically increase their risk to dangerous levels. By tracking blood levels and adjusting dosages, I could keep therapy both effective and safe. Safety is paramount. This is the opposite of one-size-fits-all dosing most of us were trained to use in medical school and residency. Instead of here's one dose, good luck, regimens can be fine-tuned, lowering estrogen here, boosting progesterone there, and yes, adding a little testosterone. The results, relief, safety, and therapy that was truly personalized. One size fits all works for hospital socks, not for hormones. Now let's talk compounding pharmacies. They sometimes get a bad rap, but when used properly, they're incredibly valuable. Here's why. Compounding pharmacies can create customized doses and combinations of hormones, often in creams or gels, based on exactly what your labs and symptoms show. That means if you need, say, 0.75 milligrams of estradiol with a specific balance of progesterone and testosterone, they can make it. Try finding that at your local chain pharmacy. It's not going to happen. And it's not the Wild West out there. Compounding pharmacies have governmental and private oversight to ensure quality. The ones I worked with followed strict standards, and honestly, their prices were almost always better than what women would pay at a retail pharmacy, even with insurance. Important note though, not all bioidentical hormones come from compounding pharmacies only. Some FDA-approved, off-the-pharmacy shelf hormones like estradiol patches and micronized progesterone are bioidentical too. In my practice, I often used a mix. FDA-approved products for convenience, compounding for precision. The bottom line, compounding, when done correctly, isn't about hype. It's about tailoring therapy so it fits you, like a custom suit, instead of something off the clearance rack. Finally, the big question. How do you bring this up without getting brushed off? Step 1, come prepared, know your symptoms, your goals, and your medical history. Step 2, ask specifically about FDA-approved options, compounding pharmacy options, bioidentical options, and don't be afraid to ask about the doctor's experience with the different types of HRT. I think that you may be surprised by the lack of experience and training ObGyn doctors have in most aspects of HRT. Step 3, if you have no contraindications to HRT and your doctor says, oh, you just have to tough it out, find a new doctor. Life is too short to sweat through every bedsheet you own. So here's the bottom line. HRT can be life-changing, but it's not one size fits all. The right hormone at the right dose for the right woman at the right time. I'm going to repeat that one as well. The right hormone at the right dose for the right woman at the right time. Ask questions, be informed, and don't let outdated headlines or slick marketing make your decisions for you. And as usual, thank you for watching GynoMite, ObGyn with a bang. If you found this helpful, hit like, subscribe, and send this to someone who's currently Googling, am I sweating or is the house on fire? And comment if you have questions or would like me to expand on any of the topics discussed. And I'll see you next time. And this video is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or another qualified healthcare provider with any questions regarding your health. Never disregard professional medical advice or delay in seeking it because of something you've watched in this video. If you're experiencing a medical emergency, call 911 or your local emergency number immediately.